be going live now. Okay, we can begin. We are live.
Good evening, doctors. At the onset, I welcome you all to Spheracon. And today, the topic of our discussion is COVID-19 and the challenges of gynecologist. My name is Pushan Acharjee from Indoco Remedies. And today we have with us two eminent doctors, Dr. Alpesh Gandhi, who is the current president of FOXI, and Dr. Rupika Bedi, microbiologist. Because microbiologist is the one who works on infection prevention. Before we start the session, I would like to salute all the doctors for being at the forefront in this fight against coronavirus. I take the privilege to introduce to you our Managing Director, Mrs. Aditi Kare Panandikar. Madam, few words from Madam's side, we will play for you.
Good evening, doctors. It is my privilege to be able to address you as part of this forum this evening.
Let me hear something.
1 second, I'm just sharing the video.
Yeah. I thought I have done something.
Pushan, we'll just play the audio message. There is some error in the video.
Good evening, doctors. It is my privilege to be able to address you as part of this forum this evening. For the last decade, businesses around the globe have been struggling to survive and grow in an environment filled with disruptions. Little did we know that the largest of disruptions was yet to happen to us. The coronavirus, COVID-19 as we call it, we had heard of it being in Wuhan in China for almost 2 months before it hit us in India. A country as vast as ours, with its huge population, with limited medical resources and with stretched healthcare budgets, no doubt it was a correct decision of our government to bring a lockdown. This was no doubt to slow down the spread of the disease and help contain the virus. Someone has said it's up to us whether we decide to wait for the storm to pass or whether we take a call and dance in the rain. Over the last 3 weeks, we have seen doctors, nurses, healthcare providers, municipal authorities, government administration, police, all put together a fight, all risking their own lives in order to save the lives of all of us. You, the doctors, have been at the forefront of this battle we are fighting with COVID-19. And I'd like to assure you that we at Indoco are with you every step of the way. The lockdown has meant tremendous challenges for us running businesses, from making people available at manufacturing sites to moving goods has been a huge challenge. Today, across 8 manufacturing sites of Indoco, across our supply chain, with all our stakeholders in the depots, we are learning to function in this new environment simply so that we can provide you with the medicine when you need it. Medical science has made great progress and has been a boon to humanity. It took us 3,000 years plus to find a cure for polio and smallpox, more than 2,000 years to find a cure for cholera, more than 1,500 years to find a cure for measles, 350 years plus to find a cure for rubella, 15 years to find life-saving drugs for use in AIDS and HIV, only 5 years to find a vaccine for Ebola. And just 4 months after the outbreak of COVID-19, we have seen human trials begin to find a cure for the COVID-19 disease. Thousand salutes to all of you in medical profession. And we are very, very happy to support you as you take the knowledge you have got of managing this disease and the guidances and factors that you'd like to share with others in your fraternity to help them manage the COVID-19 virus better. Thank you.
Over to you, Pushan.
Thank you to Madam for sharing her view. Now we will go directly to the session, and the session will be taken by Dr. Alpesh Gandhi, who needs no introduction in the gynae segment. Dr. Alpesh Gandhi is one of the eminent and the leading gynecologists of India from the city of Ahmedabad. He is a director of Arihant Hospital and currently president of FOGSI, the body of gynecologists in India. He is MBBS, DGO, FRCOG, FICOG, has experience of more than 25 years. Dr. Gandhi was the VP of FOGSI in 2013 and also member of governing council of ICOG. Dr. Gandhi have been the first president of Ahmedabad Obs and Gynae Society also. If I see the interest area of Dr. Gandhi, says interest area is in the critical care in obstetrics, high risk pregnancy, and also he has experience in hospital management. He's an expert in hospital management, and truly in the days of COVID-19 and coronavirus, sir can give more, can share his experiences on hospital management, as well as Dr. Rupika is also there. So we are transferring to you, sir. Sir will speak on the safety measures on safety measures, safety tips in COVID-19 era. Over to you, sir.
PPT.
Yes, sir. Can you please share your presentation? Yes, sure. Just slideshow mode and we can begin.
So mode. Where it is?
Sir, at the bottom right, you can see. Right, yeah, bottom right, bottom right. The icon before the slider, sir. Yeah, right next to the book icon, on the right of the book icon.
Four dot, three dots.
Sir, right next to the, yeah. Yes, sir, right below your cursor, sir. The icon. So the one to the left, sir, this one, the red one to the book, next to the book.
This is. Can we move this documents video?
1 second, sir. So can you accept it, please?
This video is there, but I can see my picture in my slides.
Yes, sir.
Minimize this.
Yes, sir. You have control now. You can just do it. You can begin, sir.
Okay. A very good afternoon to all of you. I welcome you all to Foxy's initiatives, the webinars. As we all know, COVID-19 pandemic is the biggest health crisis. It is the biggest health challenge. This pandemic has led to an unprecedented chapter in the history for all of us as practitioners. As you all know, the theme for this year of Foxy is safety first for Indian women and Foxians. And now it looks very pertinent for this year. The novel coronavirus is an unprecedented global war to mankind. The battlefield is the hospital, and the soldiers are the medical, doctors, and healthcare providers. The novel coronavirus is a new strain of coronavirus causing COVID-19, SARS-CoV-2, first identified in Wuhan City, China. Its characteristic person-to-person transmission were documented in December 2019. The COVID-19 has a high rate transmission by droplet and through fomites. It was declared as pandemic by WHO on 11th March 2020. At present, it has reached nearly 200 countries with more than 20 lakhs cases and over 1,50,000 deaths. India declared the first diagnosed case on 30th January 2019. Fortunately, compared to the other developed world, and other many countries, India is doing well. We have 14, just yesterday in the press conference, our Joint Secretary, Health and Family Welfare, Dr. Love Agrawal declared that India has total 14,173 cases with 479 deaths and 972 new cases in 24 hours. Total tests done in India is 3,19,000 till today. It is compared to general population 0.3% positive, and when patient is having complaints, symptoms of SARI, it is 1.8% positive. As per ICMR, there is no community transmission in India, and the tests are at present done in 259 labs, of which 66 laboratories are private. number would have been much higher if lockdown has not been introduced in our country as per the ICMR. And Oxford University gives high score to India for COVID-19 management. In spite of all this very comparatively good picture than the rest of the world, certain things, few things are not so good in India. Nearly more than 250 frontline healthcare workers are infected, and this is a big number. Recently in Ahmedabad, one of the medical college, LG Hospital, there are 10 doctors and staff are infected. In Mumbai, 5 hospitals, corporate hospital and other hospitals, government has stopped because of the infection in healthcare workers and doctors. We are trying to track as many possible as pregnant women with COVID-19 in India, and we are knowing more than 20 cases at present. And there are so many cases which we may not have reached to them. So in spite of all this, if we compare the infection in pregnant women and infection in healthcare providers, then the ratio is probably may not be so good, maybe more than China, South Korea, Singapore, Hong Kong, Germany, and many other countries. And that is why on one side we are able to control the spread of the disease, but if we look at the healthcare provider infected and if we look at the number of pregnant women infected, it is not so good. And that is why safety is very, very important. What are the problems at safety? Because of possibility of asymptomatic carriers. This is the biggest threat to the safety. Asymptomatic carriers, because of false negative results of the test, because in India we are doing less testing because of the limited resources in our country. Now patients are also hiding their history. Now patients are also started to hiding their reports, positive reports. And while performing MTP, other procedures, delivery, cesarean sections, we are in close contact with our patients, which may be asymptomatic carriers. So because of all this, we are at risk, we are at high risk, and that is why the safety first is very, very required. It is the safest to consider and treat all patients as COVID-19 positive unless proved otherwise. So safety is required where and for whom? Safety is required in the waiting area of our hospital. Safety is required in triage area. Safety is required in our OPD, in our consulting room. Safety is required in our labor rooms. Safety is required in our operation theater. Safety is also required for medical legal aspects, and safety is required even at our home. Ultimately, safety for whom? Safety for ourselves, safety for our patients, safety for our staff, and safety for our family members are very, very essential. So for safety of our pregnant women, first is when to do testing in pregnancy. As per the criteria of ICMR in our country, at present, pregnant women with acute respiratory illness reporting in any stage of pregnancy with one of the following criteria: history of close contact with a proven positive patient, history of residing in a hotspot or cluster, if she herself is a healthcare worker, or when she is hospitalized with features of SARI, then only we can advise for the laboratory testing for COVID-19. It means if patient is having only close contact and no SARI, no acute respiratory illness, we cannot prescribe. If patient is having symptoms of acute illness but patient does not have any of the other history, we cannot prescribe test at present as per the ICMR criteria. For this pregnant woman with acute respiratory illness, reporting in any stage of the pregnancy with one of the following criteria, and without criteria, other criteria, we cannot at present prescribe or advise laboratory testing. And therefore, on 24th March, in the meeting with our Honorable Prime Minister during video conference, on behalf of Foxy, I represented this point, and in the ICMR, with the meeting with ICMR authority, we also presented this, and now the criteria are going to be changed, and ICMR has accepted few changes. A pregnant woman with acute respiratory illness reporting any stage of pregnancy or during postpartum period also with any of these criteria, she is able for the testing. Second, most important thing, our worry is when patient comes to us with labor pain. So now patient, pregnant woman in labor pain likely to deliver in next 5 days with any one of the following criteria: acute respiratory illness, irrespective of any other criteria. So during pregnancy, she has to be associated with any other history, acute respiratory illness with any of the following criteria. Whereas now for labor, acute respiratory symptoms, illness without any association of any criteria, irrespective of any other criteria, she is fit for the laboratory, she will be fit for the laboratory testing. So acute respiratory illness, patient in labor with acute respiratory illness, irrespective of any other criteria, when she is having fever, cough, shortness of breath, sore throat, we should advise now, we can advise for laboratory testing. Yes, this will be declared in within 2 to 3 days. This is finalized in the meeting. Now, if a pregnant woman in labor having history of direct or high risk contact of an individual who has been tested positive for COVID-19 infection, in spite if she does not have any respiratory illness problem, even though she is fit for investigations. If she is residing in a hotspot or cluster or in a large migration gathering, and if she does not have any other associated findings or complaints, even though she is fit for the laboratory investigations. So now a pregnant woman with labor pain, irrespective with acute respiratory illness, irrespective of any other criteria, will be fit for the investigations. Or a patient with labor pain with history of direct contact or high risk contact, we can advise investigation. And a patient from with labor pain from an area of hotspot or cluster, now we can advise for the laboratory investigation. And third thing is, a pregnant woman presently asymptomatic and unlikely to deliver in next 5 days, who came in direct or high risk contact of an individual who has been tested positive for COVID-19 infection, should be tested between 5 to 14 days of exposure. So these are the changes. Criteria 2 and criteria 3 will be added, and postpartum period will also be covered in criteria 1. So this is for the safety of our patients. How many types of tests? At present, there are 2 types of tests, RT-PCR, and another is rapid diagnostic test, that is antibody test. How many tests are required for a patient? If she may have first test positive, then no need of the second test for the confirmation. But if first test, and usually first test is done on the day 4 or 5 of the symptoms or history of contact, a negative test does not mean COVID-19 is ruled out. If she is not improving, if she is symptomatic, if she has history of contact, high risk contact, and if you are thinking she is likely to have COVID-19 infection, then the second test is to be done after 2 to 3 days of the first test, means usually on 7th or 8th day, second test is done. And when suppose she is turned to be positive, and after some treatment, after some time, when she has 2 negative samples, then only she is considered cured, which usually takes 14 to 28 days. So many samples are required for confirmation as well as to consider whether she is cured or not. The rapid test is a blood test that assesses the antibody response to COVID-19 infection. The advantages of rapid test are that it will cost less and test turnaround time will be shorter, few hours as compared to 1 or 2 days for the RT-PCR swab test. The result will be, we will have the result within 2 to 3 hours, and it is expected that the rapid test will be available in India soon in next few days. Now, just yesterday we have now from China we have received the kits. Another important is regarding the interpretation of this test. When both the IgG and IgM both are negative, then there is no exposure or exposure within 5 to 7 days. Usually medical treatment is not required. If symptoms develop, test should be repeated, otherwise nothing to be done, and usually they are not infectious but can get infected themselves if exposed to a carrier. When IgM is positive and IgG is negative, it means there is a recent exposure. It is between 7 to 14 days. We should confirm with the RT-PCR test. Medical care is required, and these are the individuals which can spread the infection to others and needs to be isolated. When both IgG, IgM are positive, then the exposure to infection is usually between 14 to 21 days. Confirm the diagnosis by RT-PCR test. Usually they are on the road of recovery. Medical care usually will not be required, and risk of transmission of infection from this individual is low, especially if they are asymptomatic. And when IgM is negative and IgG is positive, it means exposure to infection was more than 21 days ago. Immunity has already developed. These individuals who have recovered from a clinical or subclinical infection, they do not require medical care, and they are not likely to be carriers or transmit infections. Again, it is important what is the reliability of this test. Nasal swab will detect only 2/3 of the cases, and pharyngeal swabs will detect only 1/3 of the cases. So it is important to know 1/3 of the cases with nasal swab we cannot detect. It means in many cases we may require second test also. And so single test negative does not mean patient does not have the infection. With regard to vertical transmission emerging, previously there were no evidences, but now there are few emerging evidences which suggest that the vertical transmission is possible. Although the proportion of pregnancies affected and the significance to the neonate has yet to be determined, 2 reports have published with evidence of IgM for SARS-CoV-2 in neonatal serum at birth. Since IgM does not cross the placenta, this is likely to represent a neonatal immune response to in utero infection. Where to send for the test, where we should send our patient for the testing, there are centers started by the state governments for the diagnostic test in each state. There's a list of ICMR approved laboratories, 259 laboratories, and the list is there on the website of the ICMR. So from this website, we can come to know which are the centers surrounding or in nearby area, and there we can send our patients for the test. Other laboratory tests which may be required are CBC, platelet count, fasting blood sugar, TSH, PTA, PTT, SGPT, SGOT, serum bilirubin, LDH, creatinine, electrolyte, serum lactate, urine, X-ray, CT scan, sonography. Many of these tests may be required when patient is admitted and when critically ill. Laboratory findings that have been seen with COVID-19 infection are leukopenia, lymphocytopenia, mild thrombocytopenia, mild elevation of liver enzymes, other acute infection markers. CT scan and other imaging modalities usually show patterns consistent with atypical pneumonia. And if X-ray or CT scan is needed for a pregnant woman, there should be provision of an abdominal shield to protect the fetus from radiation exposure. And informed consent should be taken. But the important is another important investigation is NL ratio, neutrophil lymphocyte ratio. There are now 2 studies which suggest that if neutrophil lymphocyte ratio is more than 3.1 and if age is more than 50 years, patient is likely to become severely ill and he or she may require admission in ICU. So for the prediction of the severity of the disease, this NL ratio is now getting more and more popular in patients, more and more utilized in patients admitted or in ICU, or when it is believed that this patient is having some serious disease, spread of the disease, viremia. Why are precautions necessary for healthcare workers? Healthcare workers are at high risk of acquiring the COVID-19 infection when they are caring for patients. This is because of the contact with large number of patients, close contact and procedures where there is spray, aerosolization or splash of body fluid. There is a risk of spread of infection from an infected patient to the healthcare provider and then onward spread to more patients and the population at large. It has been estimated that about 20% of the healthcare workers who care for COVID-19 infected patients in Italy acquired the infection. But at the same time, in Singapore and Hong Kong, because of the adequate use and supply of PPE and other protective measures, there was no transmission to healthcare provider. So the 3 principles for safety of healthcare provider: social distancing, use of appropriate PPE, personal protective equipment correctly, and chemoprophylaxis. As for the general population, the healthcare workers should also consider social distancing as the cornerstone of prevention. Whenever possible, maintain a distance of minimal at least 1 meter from patients and other healthcare workers. However, this may not be feasible during examination, inpatient care and procedures. Remove all non-essential items from the consulting room and examination room. Regular hand washing with soap and water or alcohol-based rubs for at least 20 seconds after touching any patients or her case papers. Patients should be offered appropriate mask. Now the WHO has substantially changed its recommendation on the use of mask. In the early part of the pandemic, masks were thought to be necessary only for the symptomatic individuals. However, more recent guidance suggests that every individual should wear a mask to curtail the risk of infection. And so now many authorities and many of the municipal corporations also declare mask compulsory for all the citizens. The ideal mask is the FFP3 mask. However, there is very limited availability of this mask. Therefore, a practical solution could be N95 mask. FFP3 mask should be worn only by healthcare providers, patients, and those caring for infected people directly. The public at large can use simple masks. In some cities of India, civic authorities have noticed that mask use is mandatory in public places. Now, coming to the personal protective equipment for the safety of our healthcare workers, problems are availability of the PPE, availability in a quantity, then problem of quality of PPE, problem of knowledge of which PPEs, which equipments are required for whom, then the problem at rational use of these PPEs. Government of India has approved 39 manufacturers to provide the PPEs. Which PPE is required for me is very, very important to know, and which marks should be wear is very important. There are 3 levels of care. For level 1, when healthcare worker is in the pre-examination triage or OPD, he or she requires protection by protection disposable surgical cap, disposable surgical mask. If N95 mask is available, it's good. Otherwise, disposable surgical mask, 3-layer mask will be sufficient. Also will be sufficient. Work uniform, disposable latex gloves, and disposable isolation clothing. Level 2 protection is when we are working in fever OPD or non-respiratory specimen examination, or when we are dealing with the suspected or confirmed patients, imaging examination of suspected or confirmed patient, or healthcare worker includes working in cleaning of the surgical instrument used with suspected or confirmed patients. They require disposable surgical cap, N95 mask, work uniform, disposable medical protective uniform, disposable latex gloves, and goggles. In level 3 protection, those who are working in intubation, resuscitation of suspected confirmed patients, or when they are there's a risk of spray or splash of respiratory secretion or body fluid, or when they are involved in surgeries, procedure, delivery of suspected or confirmed patients, or in autopsy, they require protection level 3, in which disposable surgical cap, N95 mask, work uniform, disposable medical protective uniform, disposable latex gloves, full face respiratory protective devices, or power air purifying respirator are required. And we should know the procedure of wearing, which is known as donning, and removing doffing of the PPE should be strictly followed. Proper techniques should be strictly followed. So we should not worry, we should not use any equipment for any procedure or any place. It should be rationalized use of this equipment. And in the event that appropriate gear of PPE is not available at a particular unit, consider transferring the patient to a center where it is available. In India, total 116 nodal centers are identified as the designated COVID-19 clinics or hospitals. They are the better equipped centers. So if you do not have the PPE, then transfer the patient where better equipped, which are the better equipped centers. We should know the nodal centers in our state. It is also available in the website and Arogya Setu app. And if an emergency situation is there where we cannot ship the patient and the PPE is limited, then it should be allocated to the workers who are caring for pregnant women who are a pregnant woman who is confirmed or suspected with symptoms suggestive of acute respiratory illness, or those who are in close contact of the confirmed cases. Now coming to the third safety, third point of the safety for the healthcare worker, that is chemoprophylaxis, hydroxychloroquine. An earlier study in which hydroxychloroquine was used was a small study comprising of 24 patients. This study was criticized. However, the same group has come out with a larger study of the success of hydroxychloroquine and azithromycin in a larger cohort. They found a rapid fall of nasopharyngeal viral load with 83% negative at day 7, and on day 8, 93% cure. Virus cultures from patient respiratory samples were negative in 97.5% of the patients at day 5. Consequently, patients were able to be rapidly discharged from ICU with a mean length of stay of 5 days. So this is for the treatment, but it is also suggested that for prophylaxis, it also works. The Indian Council of Medical Research, ICMR, also recommends the use of hydroxychloroquine as prophylaxis for asymptomatic healthcare workers caring for suspected or confirmed COVID-19 infected patients. The recommended dose is to take tablet of 400 milligram hydroxychloroquine twice a day on day 1, and then once weekly for next 7 weeks. The medicine should be taken with meals. It is contraindicated in cases of non-sensitivity to the drug, or if a healthcare worker suffers from a cardiac problem or G6PD deficiency or retinopathy. So it is always better to take ECG before starting hydroxychloroquine. Healthcare workers should not fall into a false sense of security when pharmacoprophylaxis is being used, and other preventive measures should be followed. In case of accidental occupational exposure, we should follow the protocol along with this pharmacoprophylaxis. Now there should be arrangement in the hospital existing healthcare structure at the triage area and at other places for the safety Hospitals should have proper triage area and triage system. Hospitals should have isolation zones, which should include outpatient ward and ICU. There should be dedicated labor room and operation theater demarcated for the COVID-19 non-infected and infected women. If the hospitals are managing both types of patients, COVID-19 as well as infected and non-infected patients, if they are managing both types of patients, then they should have the dedicated separate labor room and operation theater for the patients who are confirmed COVID-19 infected. Or the hospital itself should be demarcated only for the COVID-19 infected women or only for the COVID-19 non-infected patients. So for the safety in triage area, do not touch the patient, do not touch her papers, ensure her vehicle is kept waiting till the COVID-19 screenings questionnaire is completed, maintain a distance of 2 meters if possible with her and other patients, give the COVID-19 screening questionnaire to her. If the questionnaire is negative, give her hand sanitizer for hand wash and a 3-layer mask to wear. Send her to OPD or labor room or operation theater or HD or ICU wherever her further care is required, and do not allow more than one relative to accompany her. And in this COVID-19 screening questionnaire form, we should ask whether patient has complaint of fever, whether patient has complaint of severe acute respiratory illness like cough, cold, running nose, sore throat, difficulty in breathing, shortness of breathing. We should inquire about the history of travel, history of contact, history of residing in cluster, history of hospitalization, history of any associated comorbidity, and whether she is working as a healthcare worker or not. So if the COVID-19 screening questionnaire is positive, provide N95 mask to a patient and her relative and refer her to the fever clinic or to the designated center wherever she requires her care. Patient to be shifted if suspected or confirmed, ensuring that patient does not enter the hospital and goes directly to the isolation ward, labor room, operation theater, ICU through isolation channel only. If the hospital does not have isolation ward for COVID-19, shift her directly to the COVID-19 designated center or hospital for further testing and care, and inform the doctor working at fever clinic or COVID-19 hospital to be ready to receive her. Assessment of pregnant women without labor pain is very important. As of date, all confirmed cases are being hospitalized in India for isolation and observation to watch for further progress of the symptoms. We should try to recognize whether the patient is critically ill, whether she is having any symptoms or findings which is critically ill. Most women will not need hospitalization or critical care, but if she has any such findings, she should be admitted to ICU from the triage area itself. If she has tachypnea more than 30 respiratory rate per minute, if she has hypoxia, SpO2 is less than 93%, if she has imaging showing more than 50% of lung involvement indicated need for critical care, or when the quick SOFA score is positive more than or equal to 2 score, then she should be directly guided and referred to ICU. Policy for safety of patient and gynecologists in OPD and operation theater. FOXI has published the short-term advisory. For this, routine antenatal visits for patients having no complaints or at low risk gynecological complaints of a chronic nature and new treatment for fertility care should be deferred. Time-sensitive treatment and care should be continued, like 2 obstetric scan and MTP. If possible, visits for ANC should be restricted to 3 to 4 only, at 12 to 13 weeks scan, at 18 to 22 weeks scan, at 32 weeks, and in the last month. Vaccination and scan should be planned during these visits only. Use of telemedicine is now permitted and recommended by MCI, and resource should be taken to it to facilitate minimum outpatient attendance. Elective surgeries and diagnostic procedures can be deferred after informing a patient about the risk of transmission of COVID-19. And medical and paramedical and other staff members should be trained in infection prevention policy. For the safety in OPD, always put on apron, surgical cap, gloves, N95 mask continuously in your consulting room. Do not allow any patient without wearing a mask in the consulting room. Do not allow any relative to enter in your consulting room, or if needed, allow only one relative. Try to keep 1 meter distance from the patient whenever possible, and whenever possible, do not touch the patient or her papers. If examination is required, wash your hands for 20 seconds with soap and water after each examination. Keep minimum items and furniture in the office and disinfect the surfaces frequently. Medical management, we all know that hydroxychloroquine in a dose of 600 milligram, 200 milligram thrice a day with meals, and azithromycin 500 milligram once a day for 10 days has been shown to give virological cure on day 6 of the treatment in 100% of the treated patient in one of the studies. Alternative dosage regime is hydroxychloroquine are to be given 400 milligram twice a day on day 1, and then 400 milligram only once a day for next 5 days. And chloroquine can also be used as an alternative in the dose of 500 milligram twice a day for 7 days. Some authorities also recommended azithromycin should be added only when there is a suspicion of superadded bacterial infection. Antiviral therapy like lopinavir and ritonavir are suggested, should be considered as a possible line of treatment for those who have chronic disease and immunocompromised or uncontrolled diabetes. In India, some of the health authorities also prescribed a regime of oseltamivir 75 milligram twice a day for 5 days in conjunction with hydroxychloroquine. This recommendation is based on the experience of the H1N1 experience, but at present it is not recommended by ICMR or any other authority. Corticosteroid, it is safe and beneficial for lung maturation between 24 to 34 weeks in women at high risk of preterm birth. Tocolysis, vitamimetics should not be given. NSAIDs like ibuprofen and indomethacin should be avoided. Paracetamol is safe drug can be prescribed, and if required, antibiotics safe in pregnancy can be prescribed. One interesting webinar was, very informative webinar was organized by FOXI, where Leona Poon was the faculty, and she has nicely mentioned the PPE required. Is suppose in our OPD outpatient department we are performing sonography, then which PPE is required. She has very nicely mentioned. If patient is asymptomatic and there is no history of travel, occupational hazard, cluster or contact, then only hand hygiene, surgical face mask and disposable gloves are required. But if she is asymptomatic but TOCC positive, then the respirator N95 mask, disposable protective gown and goggles or face shield is required. Similarly, when suspected or confirmed cases, we require all these things. MTP DNA is a frequent practice, and we should also have some policy for the safety. Abortion care is time sensitive and should be provided. No need of abortion because of fear of possibility of fetal affection due to coronavirus. Because of the fear, patient may ask for MTP, but just because of the fear that she might have coronavirus infection, this should not be encouraged. Emergency contraceptive pills can prevent 90 to 95% unwanted pregnancy when taken in within a few days. Then this can prevent them from hospital visit. No telemedicine services for MTP. If it is found suitable, medical abortion can be considered for early pregnancies up to 9 weeks. And there is no need of sonography to confirm pregnancy, gestational age, if patient is reliable, history is reliable. Also ask her to fill the COVID-19 screening questionnaire form. If patient is having positive history or suspected or having any symptoms, please refer or advise for the testing before performing MTP. If test is positive, send her to the COVID-19 designated hospitals for MTP, or if she requires DNA. Minimum staff should be allowed in the operation theater. You yourself, your anesthetists and your assistant nursing staff, only 3 are enough. Do not allow any relative inside the operation theater. And if you have the PPE, then wear full PPE. Otherwise, at least full gown, gloves and N95 mask should be wear. Not to use sonography just for follow-up or just for the confirmation of the procedure. For the labor room triage, the women should call in advance to alert the maternity unit about her arrival whenever this is possible. The women should use private transport or an ambulance to reach the maternity unit. This should be made with the appropriate don PPE at the reception itself. Reception and triage in the same room has to be used for admission in labor and delivery. This should be a room with negative pressure, but this is not available across India. Most of the places keep the room free from any unnecessary items which would act as infected fomites later. There should be restriction on the number of attendants allowed with the women. There should be a restriction on the entry and exit of the non-essential staff into the room. The companion of the women should be treated as infected and all precautions should be taken. The women should wear N95 mask throughout the triage and in the labor room when she is suspected or infected. And management of labor and delivery in women with COVID-19 infection. In all circumstances, maternity care providers should continue to provide respectful, skilled maternity care and support. She should be delivered in a separate delivery room or she should be operated in a separate operation theater. Neonatal resuscitation corners should be isolated at least 2 meters away from the delivery table. Depending on the clinical picture and severity of the condition, a multi-speciality team may be involved. Anesthetists and neonatologists should be informed of such a woman presenting in labor. Timing of delivery should not be altered just because of the COVID-19 infection. It has no effect on the route of the delivery or the timing of the delivery. The presence of infection is not an indication to induce labor or to deliver the women. The exception to this would be the critically ill pregnant woman, where delivery may be indicated to relieve the extra metabolic or pulmonary load. If she is having extra metabolic or pulmonary load, and if critical care specialist or if a gynecologist thinks that it is better to deliver her, then this is the exception. In labor, monitor the respiratory status with the pulse oximeter. Mainly, we should look for the respiratory rate, pulse rate, oxygen saturation, and also we should look for the difficulty or shortness of the breath. If there is a deterioration of these features, intensive care measures should be taken and she should be shifted to the ICU. As such, pregnant women with COVID-19 infection can be allowed to go to the labor, and indication for intervention should follow standard obstetric practice only. Level 3 PPE for all healthcare providers and support staff with every examination and contact. And IV access should be established and fluid should be restricted. It may be prudent to offer continuous electronic fetal monitoring in labor for women with COVID-19 infection. There are few studies where it is found that some of the fetuses getting the fetal distress, as well as it is very difficult to use stethoscope, and when we wear the PPE, it is very also difficult to hear the heart sound with the stethoscope. So continuous fetal heart monitoring is very important. Unnecessary use of sonography in the labor room should be avoided. PV examination should be limited and performed only when it is highly indicated. Second stage of labor should be cut short to prevent maternal exhaustion and reducing maternal efforts in case where there is a respiratory involvement by the infection. Delayed cord clamping, there is a debate between early cord clamping and delayed cord clamping, but most of the studies suggest that delayed cord clamping at 1 minute is advised. At present, pregnant women have almost universally been delivered by cesarean section when they present in labor with COVID-19 infection. However, this is no proven scientific rationale for this. The care of the newborn is very, very important and should be in the hands of the neonatologist and pediatrician. Neonates born to mothers with COVID-19 infection within 14 days of delivery or up to 28 days after birth should be tested for the COVID-19 infection. Symptomatic neonates should also be exposed to close contact should also be tested for the COVID-19 infection. If symptomatic neonate, then specimens should be collected as soon as possible. And if asymptomatic and neonate is roomed in with the mother, and if the mother is COVID-19 positive, then the baby's initial sample is, if baby's initial sample is negative, then another sample should be repeated after 48 hours. If it requires cesarean section, then it will be performed in a dedicated COVID OT only. Cesarean section is reserved only for the obstetric indications. Proper consent should be taken. We should explain her that this cesarean section may take some more time because of the wearing of PPE, because of the less staff in the operation theater, and because of many other problems. Call the anesthetists and neonatologists, minimize the number of the persons and movement in the operation theater, give pre-operative antibiotic prophylaxis. Blood transfusion should be performed only if it is indicated, because we should now predict that blood crisis may happen because of there is no blood donation camps at present are organized. Cleaning and fumigation and biomedical waste management as per the protocol. Post-op round is to be taken with full PPE or can be taken even on video telemedicine. If she is okay, if she does not have any problem, any complaint, then with video telemedicine, one can also take round with the patient, discharge the patient after 2 to 3 days if she improves and there is no problem or further care is possible at home. Otherwise, patient is kept in the same hospital. There is no evidence that epidural or spinal anesthesia or analgesia is contraindicated. COVID-19 infected women who is fit enough to labor can be offered if she wants labor analgesia. If a woman who requires cesarean section, for most of the women, spinal anesthesia by standard technique is suitable. However, in the situation where there is respiratory compromise, general anesthesia and subsequent ventilation will be needed. If general anesthesia is administered, pre-oxygenate the patient for 5 minutes with 100% oxygen and perform rapid sequence induction to avoid manual ventilation of the patient's lung. The need for using full PPE is reiterated. Place a high efficiency hydrophobic filter between the face masks and breathing circuit or between the face mask and reservoir bag to avoid contaminating the atmosphere. Take all the care for the aerosols. And pregnancy is known to be hypercoagulable state, and emerging evidence also suggests that individuals admitted to hospital with COVID-19 are also hypercoagulable. So we should be watchful. And at the end, for the safety of our staff, if we have staff of more than 60 years of age, should be allowed to stay at home with pay. Give leave with pay to staff who has comorbidities like diabetes mellitus, asthma, COPD. Similarly, in a big or public hospital or a designated hospital, 1 week work followed by 1 week or 14 days quarantine. If patient load is manageable, to reduce the viral load in our staff member, try to see the duty hours for the staff does not exceed more than 8 hours. If possible, keep it up to only 6 hours to reduce the viral load in our paramedical staff. Give N95 mask and gloves to them. Educate them for proper hand hygiene, proper respiratory hygiene, proper social distancing and surface disinfection. And after working in the hospital, when we are reaching at home, remove your shoes outside the home. Do not wear the ornaments during the practice. Immediate take bath, wash the clothes, practice social distancing at home, take nutritious diet to build up the immunity, and when you are in close contact, take chemoprophylaxis. We are dealing with a pathogen about which little is known. A lot of new data is emerging. It is important for each country to collect data to facilitate further research on the very important aspects of the interaction of coronavirus infection and pregnancy, and to facilitate data collection and systemize it. Foxy has proposed a registry of pregnant women infected with COVID-19 and the format is available. We urge every clinician to report every case so as to allow a comprehensive data collection. This is the link of this National Registry of Foxy, and this link is this registry is also uploaded on our Foxy's official website. So from there also you can have this registry. It is also there on our Foxy's app, from which you can get this registry. If at all you come across any such patient, please fill the data and submit this in the Foxy's registry. Thank you very much for your patient hearing. Stay safe, take care, take precautions, stay healthy. Thank you very much.
Thank you, sir. Thank you for your such detailed tips on the safety for the gynecologists. Few questions have started coming. Those who have joined late, I am again welcoming them in the Speracon. And there is a section for question and answer. You can put your questions there. We will have the question and session after the session of Dr. Rupika. Before we go to the session of Dr. Rupika, I again take the privilege to introduce our MD, our Managing Director, Mrs. Aditi Kare Panandikar, Madam. I understand last time there was some problem in playing the video, only sound came. I just take the pleasure to run the video of Madam before going to the session of Dr. Rupika Bedi.
Good evening, doctors. It is my privilege to be able to address you as part of this forum this evening. For the last decade, businesses around the globe have been struggling to survive and grow in an environment filled with disruptions. Little did we know that the largest of disruptions was yet to happen to us. The coronavirus, COVID-19 as we call it, we had heard of it being in Wuhan in China for almost 2 months before it hit us in India. A country as vast as ours, with its huge population, with limited medical resources and with stretched healthcare budgets, no doubt it was a correct decision of our government to bring a lockdown. This was no doubt to slow down the spread of the disease and help contain the virus. Someone has said it's up to us whether we decide to wait for the storm to pass or whether we take a call and dance in the rain. Over the last 3 weeks, we have seen doctors, nurses, healthcare providers, municipal authorities, government administration, police, all put together a fight, all risking their own lives in order to save the lives of all of us. You, the doctors, have been at the forefront of this battle we are fighting with COVID-19. And I'd like to assure you that we at Indoco are with you every step of the way. The lockdown has meant tremendous challenges for us running businesses, from making people available at manufacturing sites to moving goods has been a huge challenge. Today, across 8 manufacturing sites of Indoco, across our supply chain, with all our stakeholders in the depots, we are learning to function in this new environment simply so that we can provide you with the medicine when you need it. Medical science has made great progress and has been a boon to humanity. It took us 3,000 years plus to find a cure for polio and smallpox, more than 2,000 years to find a cure for cholera, more than 1,500 years to find a cure for measles, 350 years plus to find a cure for rubella, 15 years to find life-saving drugs for use in AIDS and HIV, only 5 years to find a vaccine for Ebola, and just 4 months after the outbreak of COVID-19, we have seen human trials begin to find a cure for the COVID-19 disease. 1,000 salutes to all of you in medical profession. And we are very, very happy to support you as you take the knowledge you have got of managing this disease and the guidances and factors that you'd like to share with others in your fraternity to help them manage the COVID-19 virus better. Thank you.
And please unmute.
Coming back to the Spheracon, you can also see the Spheracon in YouTube. Live streaming is going on in the YouTube. So lots of questions are coming for Dr. Gandhi. Sir, we have some questions. We will go to the question session after Dr. Rupika Bedi's session. Introducing Dr. Bedi, she is now associated with Narayana Multispeciality Hospital in Ahmedabad. Before joining here in the Narayana, she was in Kota Government Medical College as assistant professor. She won Chairman's Award for the best doctor in West in Narayana group of hospitals. We are privileged to have Dr. Rupika Bedi with us, who is a microbiologist, MD in microbiologist. And as a microbiologist, she is working a lot of things for prevention of infection. Over to you, madam.
Thank you. So as Dr. Alpesh has given a detailed account of how we should be preventing infections, not only in the gynec, but I think he has roughly covered something of which I'll also be covering. So it has made my work very easy. I'll be breezing through this because I think it has been a long session. You must be waiting for your questions to be answered. So we'll just go with our presentation now. My presentation is all about safeguarding the hospital, and I will be roughly covering infection prevention in various areas of the hospital during the COVID-19 pandemic. Now, about the virus, as it has already been talked about by my eminent speaker in the previous presentation, that it's a SARS coronavirus 2, it's a novel coronavirus. The virus transmits mostly through droplets and contact with surfaces which are contaminated by droplets. Now, I would just like to tell you that droplets are bigger than droplet nuclei, and they don't travel more than 1 meter. Droplet nuclei are evaporated droplets which may, because they become light, travel through air more than 1 meter. So this will be the basis of various infection prevention modalities, which we will see now. So what are the principles of IPC strategies which are associated with healthcare for prevention during the COVID-19 pandemic? Now, the infection prevention and control strategies which prevent or limit transmission are ensuring triage, early recognition and source control. Most important is applying standard precaution for all patients. Standard precaution for all patients, because in this time of transmission, we do not know who is infected. There may be some asymptomatic people who come to your hospital. So applying standard precautions is prudent during these times. Then implementing empirical additional precautions like droplet and contact wherever applicable, and also airborne precautions for suspected cases of COVID-19. Implementing administrative controls in the hospital, and also using environmental and engineering controls to prevent the spread of COVID-19. Now, to reduce the risk, we have to see transmission-based precautions, which are contact, droplet, and airborne. Standard precautions, most importantly, hand hygiene. Respiratory hygiene, we've been hearing a lot about it in all our IEC activities. We have been hearing it a lot on the TV, on the radios, everywhere. And use of mask by patient. Then patient placements like airborne isolation rooms, single rooms, cohort areas, visitor management, movement of the patient in the hospital, critical care, operation theaters, dialysis. I'll be going through very fast through all these things: environmental decontamination, waste, linen management, and management of equipment and care environment, and handling the deceased. Now, outpatient departments. In-person visits should be avoided. As much as possible, usually promote online consultations or telemedicine to reduce the contact, and discontinue or postpone routine visits. This applies to all kinds of patients. Then this is one slide where you can see that the setting, the activity, the risk, the PPE which is to be used in those areas, like a triage area where you're going to triage people. Just provide a simple triple layer mask to the patient. A 3-ply surgical mask will do, since the mask will cut the droplet transmission from the patient to the healthcare provider. The risk in the triage area is moderate, and a triple layer mask and gloves are the appropriate PPE. Now, PPE, as I've come to know during this pandemic, is even at my place, the doctors think PPE is that Corona kit. Oh, that whole white thing with that visor, everything. PPE is personal protective equipment, which is gloves, mask, caps, and the uh, uh, shoe covers, anything. And PPE is to be based on risk assessment. So, thermal screening station where the temperature is recorded with an infrared temperature recorder, the triple layer mask and gloves will do. Similarly, in the screening area or help desk registration counter, again, a triple layer mask and gloves. Waiting area where the patient is waiting and the nurses and the paramedics are interacting with the patients, you need a triple layer mask and gloves. And you minimize the visitors who come with the patient, and doctor's chamber or the clinical consultation management where no aerosol generating procedure allowed. We will be going to what are AGPs or aerosol generating procedures. You would still do with a triple layer mask and gloves. There's a lot of controversy about who should be using an N95, why am I not being given an N95, and what does the N95 do? And the visitors accompanying the patients who require, who support the patient in navigating various areas, the risk is low. A triple layer mask would do. Again, I would say discourage visitors, and visitors should be kept to a minimum. Standard precautions, as I have said, and I think are the cornerstone of every infection prevention control program, including coronavirus pandemic, is hand hygiene. It cuts down 70% of all infection risks in all settings. So it is essential to reduce the transmission. You can use a simple soap and water to wash your hands if you do not have an alcohol-based hand rub with you. An alcohol-based hand rub should be having ideally more than 65% of alcohol, isopropyl or ethanol, and it should be rubbed adequately for at least 20 seconds. But knowing what coronavirus is, it is a lipid covered virus, and hence it is easily washed away with the soap and water. So you must be using soap and water copiously when you are come in contact with the patient or the patient surrounding or patient when you examine the patient, whatever. So hand hygiene, as you know, the 5 moments of hand hygiene, and all of us have these posters in our OPDs, in our nursing homes, in our clinics, in our hospitals, wherever. And this is the time to just go through it briefly, like before patient contact, before aseptic task, after blood body fluid exposure, after patient contact, and after contact with the patient surroundings. And you must always, always, always remember, I cannot stress it enough, to keep your hands clean. Then respiratory cough hygiene. Respiratory and cough hygiene, of course, India is new to this now because we have a habit of coughing in the open. All of us may be coughing in our hands or sneezing in our hands. Now, this cough hygiene has to be taught to the healthcare providers as well as to the patients, that they should be encouraged to minimize potential COVID transmission through good respiratory hygiene measures like covering your cough with a tissue and a handkerchief. So as I said in the beginning, give a mask to all the patients who are coming to you in your OPDs or who are coming to you in the triage area. Give them a mask because that will minimize the droplet spread through coughing or sneezing. Hands should be clean using soap and water if possible. Otherwise, you can use a alcohol-based hand rub after coughing, sneezing. And whatever tissues or masks are to be disposed should be disposed in a dustbin. They should not be thrown here and there. And encourage the patients and also the doctors to keep their hands away from the eyes, mouth, and nose, since the virus enters through the droplets which impinge on the conjunctiva or the mucosal membranes of the mouth and nose. Now, patient use of face mask. When should the patient be using a face mask, and what kind of face mask should be given to a patient? So, in the common waiting areas or during transportation and where tolerable and appropriate in clinical areas, symptomatic patients may wear a surgical face mask. The aim of this is to minimize the dispersal of respiratory secretions and now, there is a huge controversy. Again, I'm stressing this, that surgical mask should be worn or an N95 should be worn, and who should be wearing whom. A surgical mask cuts down around 75% of the droplets uh, which may cause infection. But an N95, as you know, cuts down 95% of aerosols at 0.3%, 0.3 micron size, 1 to 5 micron less size droplets. It cuts them down. So if a person is symptomatic, if he or she is coughing, it's prudent to give him or her a surgical mask, which may suffice. There is no need to give an N95 to a patient. I think N95 should be given to a medical worker who requires them the most, and that too during aerosol generating procedures. Then PPE use in IP area. This is a very, very simple slide. I've simplified it a lot for you. So healthcare workers, those which provide direct care to the COVID-19 patients, the type of PPE is medical mask, gown, gloves, and eye protections like goggles or face shield. and aerosol generating procedures which are performed on COVID-19 patients. You can use a respirator, which is N95, or a filtering face piece 2, which is FFP2 standard or equivalent. Gowns, gloves, eye protection, and apron. So these are the only things you need to remember. There should be no confusion as to who is to wear when. The references to the same can be found on the WHO site on infection prevention and control during the COVID-19 pandemics. So this is a visual guide to safe PPE. This is from the NHS UK. Now, if you see this slide, it is very easy to see what is to be worn where. Aerosol generating procedures in high risk area require eye protection. Yes. A filtering face piece respirator or the FFP2, which is the N95 equivalent. A long sleeve fluid repellent gown and gloves. Whereas a general contact with confirmed or possible COVID-19 cases, you can wear a eye protection based on your risk assessment, whether or not you will be coming in contact with the patient's bodily secretions. A fluid resistant surgical mask or a simple 3-ply surgical mask, disposable apron and gloves. But the most important thing is cleaning your hands before and after patient contact. That's 5 moments, and also cleaning all equipment that you are using according to the local policies. You use the appropriate PPE for the situation you are working in. Take off your PPE safely. So donning and doffing, as sir has already talked about in his earlier presentation, is very, very important before you just jump onto the bandwagon of wearing full PPE without knowing what to wear when, and most importantly, how to take that PPE off. And hand hygiene still remains the key thing. If you remove your mask by touching it in the front, which I see so many healthcare providers do, I have seen it in my own hospital that I see doctors going around with mask hanging around their noses here, or maybe hanging in their necks, and then they take it and put it back on. Now, this is a very dangerous practice because the front of the mask is the area where the respiratory droplets or the contamination from the patient impinges and dries. And if you touch those things, you are contaminating your hands, you're contaminating your surroundings with that, and you might accidentally touch your eyes, nose, or face during that time and inadvertently infect yourself. So most important is hand hygiene while you wear a PPE, and you take it off also safely. And when you are wearing a full PPE, you should take breaks and hydrate yourself regularly. Now, a lot has been said about N95s and aerosol generating procedures. Now, what are aerosol generating procedures? What are actually aerosols? Aerosols are solution, air particles in solution. Very, very small, up 1 to 5 microns in size. They are very light, so they remain suspended in the air and they are breathable. They reach your alveoli. So what are the various aerosol generating procedures? They are open suctioning of the airways, sputum induction, cardiopulmonary resuscitation, endotracheal intubation and extubation, non-invasive ventilation like BiPAP and CPAP, bronchoscopy, and manual ventilation. Also autopsy and certain surgical procedure where drilling and all happen, like transsphenoidal surgeries or maybe orthopedic surgeries, wherever. These are also areas where aerosols can be generated. Now, wherever aerosols are there, they are very, very small. They can only be removed through ventilatory measures, like maybe in a negative pressure room or wherever, and or adequate ventilation has to be there for the removal of them because they remain suspended in the air for a long time. So to protect yourself from breathing in those aerosols, you require an N95. So I think it should be very clear to you who requires an aerosol, who requires an N95 and who does not. I'll go department wise now. For the oncology department, because I come from a multi-specialty hospital where I need to address the needs of each and every consultant who comes to me with questions. What am I supposed to do? What are your recommendations for my department? So here they are. I've summarized them very, very briefly. So oncology, if you have patients coming to you, do a universal screening at entry, do temperature checks, travel and exposure history as has already been discussed, promote online consultation, minimize contact with the patient. If he or she has fever and cough, evaluate with a PCR or CT. Then classify as category A, which requires your urgent attention, category B, which can be deferred till 4 to 6 weeks, and category C is routine. Ask the treating oncologist for switch to oral agents if that is possible. Prolong infusion intervals if possible, and protocols if deferrals are feasible. Do not withhold any critical anti-cancer or immunosuppressive therapy. So I think you have to go on a case-by-case basis. You have to weigh the risk and the benefits with the patient itself. And these are the general guidelines which should be there. And because as an infection preventionist, I face a lot of these things. So always take the consultant into consultation with you and ask for the possible things by which you can circumvent the procedures which can cause healthcare workers being exposed or the patient who's carrying this infection and coming to your facility. So pregnant women, Sir has already discussed a lot. That's why I just made a very, very small slide with this. So there is no increased risk in pregnant women, although as I discussed, some reports are coming in that children are born with IgM and IgG. That means in utero vertical transmission may be possible because the IgM is big enough. It does not cross the placenta. So if the child has been found with IgM, that means he was exposed to this virus in utero. But as far as I have seen, there has been no increased risk in pregnant women. The usual precautions apply. You do not need routine testing. Sir has already given a beautiful and a very lucid lecture on that. And no virus is present in the amniotic fluid of breast milk. So in the labor room, etc., if you are doing normal, if the patient goes into normal labor, I don't think PP with a full thing is required. Yes, emotionally you might feel unprotected that you should be wearing an N95, but I don't think amniotic fluid, since it does not carry any virus, and neither does the breast milk, so you should not withhold the mother from feeding her infant. And she can do so, and even if she is symptomatic or she is a suspect, she can wear a face mask and do hand hygiene before feeding her baby. Express breast milk is also safe. Holding baby is also safe, provided she knows how to follow the standard precautions. She follows respiratory etiquette. All those things are safe. And sir has covered all those, so I'll just skip it. In the operation theaters, postpone elective surgeries and endoscopies. Theater remains positive pressure. Now, this was one thing which I actually faced at my hospital, because everywhere India has negative, positive pressure operation theaters. Positive pressure means that the air goes out of the chamber, not inside. Whereas airborne transmission, for airborne isolation, we require negative pressure. Now, we cannot make the OT negative pressure, but what we can do is intubation and extubation should ideally be done only by the anesthetist separate, preferably negative pressure area, or in the OT 15 minutes before the entry. Now, because I said intubation and extubation are aerosol generating procedure, they will require an N95 and eyewear, face shield itself. Limit the manpower in the OT and let the OT ventilation take care of the aerosols generated. You should not be, because positive pressure cannot be done away with. If you do that, there will be cutting down of the air conditioning. So leave the door closed for 30 minutes after surgery, so that all the air changes which are there, they can take away the aerosols generated, and then you do your routine cleaning with your hospital approved disinfectant. Endoscopy, again, postpone elective work, pre-screen the patients. All people in the endoscopy suite must wear PPE, gown and shield. All procedures, especially upper GI endoscopy, are considered high risk. Avoid procedures that require carbon dioxide insufflation and avoid removing the caps on scopes. Blood bank, again, triaging of all as usual, ensure social distancing. All staff should be wearing 3-ply masks. A cough etiquette, needless to say, and hand hygiene, environmental disinfection with any of your hospital approved disinfectant. The Government of India prescribes use of hypochlorite or maybe Lysol, whatever is easily available to you. Environmental disinfection should also be a very important part in breaking the chain of infection. Evaluate the donor for travel, any contact history, personal illness. Avoid a donor from cluster. Contact details of donor should be with you. And WHO says that there is no bloodborne transmission so far. So since it is not a viremia, therefore sometimes I have to even convince people not to wear a full PPE kit, such as the people who are in cath labs or people who are just there in the dialysis and all. A full PPE kit is not required. So as you can see from my slides, and what I have been saying from the WHO perspective is that there is no bloodborne transmission. So this should be safe. Dialysis, again, triaging is the most important part. Mask for all patients. Now, there is people who come in and you do not know, they might be asymptomatic people. We are in an area which is seeing a high transmission right now. So we have, as our policy, we have provided masks, 3-ply surgical masks for all patients who come in. Suspected COVID patients to be kept separate. If a separate area cannot be there, then the dialysis for them should be taken at the end of the day. A single dedicated staff and instrument allocation is a must. Hand hygiene, cough etiquette, and PPE based on risk assessment when caring for suspect or proven patient. So, and linen and laundry. Now, standard hospital policies are to be followed. In case of suspect or confirmed COVID case, remove the linen in a separate bag without agitating or jerking it. Disinfect with 1% hypochlorite and send for a normal wash. Else, a hot water cycle at 60 to 90 degrees in hot water and detergent will suffice. Biomedical waste handling. All waste from non-COVID areas is to be segregated and disposed of as per the Biomedical Waste 2016 guidelines. But all waste from the COVID positive area should be treated as infectious waste, including the general waste. So there should be no black bags in your COVID ICUs or your COVID care areas. Then the dead body handling. The dead body, the virus will survive as long as your cells survive. It cannot survive outside a living host. So there is unlikely risk to healthcare providers or family members who follow standard precautions while handling a dead body. Only the lungs of dead COVID patients, if handled during autopsy, can be infectious. Embalming is not allowed. The body should be secured in a body bag with its exterior decontaminated with 1% hypochlorite, and that poses no additional risk to staff that is transporting the dead body. The crematorium or burial ground staff should be sensitized that COVID-19 does not pose an additional risk. Large gatherings at such places should be avoided, of course. Bathing, kissing, or touching of body should not be allowed. And all family members must perform hand hygiene after the process. This being India, we all are habitual in taking a full bath after we come from such places. So that should not be a problem. And these are my references from where WHO technical guidelines, my own mitigation plans from Narayana, NHS guidelines, RCOG, SAGE, and Ministry of Health and Family Welfare, Government of India technical guidelines. Everything which I have discussed with you here is freely available as a free downloadable technical documents from these sites. And I would be happy to take questions from you all now.
So a few questions has come. The first question is from Dr. Regina Leo from Chennai. Why, in spite of precaution, doctors are getting infected with the corona?
Shall I answer that? Can I answer that?
Yes, ma'am. You want
Yes,
to take
yes.
it?
Yeah. So as far as I know, doctors who are getting infected from coronavirus is because they are working very, very long shifts. Sir has already said in his PPT that the shift should be around 6 hours or 8 hours to reduce the viral load. So the person who is generally working very long shifts, we see that he or she has a tendency to fudge over simple things. Maybe they did not do a proper hand hygiene. The PP was not fixed properly. The N95 which was not worn doing a fit testing, or when they were donning or doffing, that was not done in a proper way. They are not eating properly. The general immunity of the body also goes down. So these are the various causes which I think may be responsible for people catching the infection, and even having some people have even died because of those things. I don't see any other reason that PP was there and still they were getting infected. These are the only reasons why they would be catching the infection.
Right. So Dr. Balakrishnan from Calicut is asking, what is the impact of COVID in pregnancy? Will it adversely affect the baby? Does it affect possibly of father getting pregnant?
Other getting pregnant, I could not understand, but it will not have effect at present. There is no evidence that we suggest any adverse effect on fetus, no anomaly, no IUGR, no oligohydramnios, and no preterm delivery, and no abortion. At present, there is no any such evidence. It does not transmit through cord, through placenta, through amniotic fluid, and there is no need of amniocentesis to know all these things. Only just for reassurance, if mother is having COVID-19, if secured, after 2 weeks, one sonography is sufficient. There is no evidence of transmission to an adverse effect on baby.
Right. So Dr. Savita from Bangalore, she is asking about that, how far telemedicine is useful in gynecological practice? And there's one more question that if it is useful, then how the prescription she will do in the telemedicine?
So this is the new era. We all have to learn telemedicine. In the other part of the world, it is officially permitted since long. I would request just go through the amendment by MCI, which was published on 25th March. Everything in very good detail they have mentioned, and there is a format also how to write a prescription on telemedicine. So you just go through it and you will have the guidance about how to do the telemedicine practice and how to write a prescription. There are different platforms. On web you can do, there's audio, on audio you can do, on video counseling also you can do. If suppose you have not seen patient any time, it is for the first time, better to do video counseling so that you can come to know about something from the video itself. If you are knowing the patient, you have history, you are if patient is able to provide you the informations, then on even WhatsApp and other media also you can do the video, you can do the telemedicine. But for prescription, there is a fixed format. We need to follow this format. So for that, I cannot describe at present. You just go through the MCI website and you will find it. It is very simple and very handy.
Thank you, sir. Dr. Kamal Advani from Pune is asking that if RT-PCR is negative, do we need to repeat the test again?
RT-PCR, as I have mentioned, 63 to 67% positivity. So single RT-PCR, if negative, it does not mean patient does not have the COVID-19 infection. If she has strong history, if she has symptoms, continuous symptom, if she is not improving, then after 2-3 days, one should go again for a second test.
Right, sir.
There are reports where 4 tests are done. So it is not that a single test is enough.
Can I add one thing over here? Sometimes when the RT-PCR comes negative, it can be due to maybe these are certain things which I have observed. The sampling is not done properly. Sometimes it might be a oral sample which is taken, not an oropharyngeal. When we say that nasopharyngeal, oropharyngeal, some labs say you send 2 samples to us, naso and oropharyngeal. So sometimes the sampling is not proper. Sometimes the kits are not functioning properly. Sometimes there might be a break in the cold chain that happens when the sample is transported from the sample collection area to the testing lab. So like for us, if not, I don't think everybody has easy access to RT-PCR at their facility. Even we are doing it through a third-party lab. So we take care to send it in a cold chain, that is, and the virus is might get you, so you say that the yield might not be there if the cold chain is not maintained, the sampling is not proper, sometimes the kits are not proper. And as sir has said, yes, if the person is negative, that does not mean that he or she is negative. If you have a strong clinical suspicion that he or she has a travel history or cluster areas she or he belongs to or comes from a hotspot, then there are other ways of ascertaining whether he or she may be harboring a COVID. And as of now, antibody tests are available only for hotspot or maybe for clusters or something, like they're not available for commercial use. But once we have use of them, we can also use them to see whether the person was exposed to the coronavirus or not, because they become positive 7 days or 7 to 8 days in the course of disease. The virus will be there in the first week. So later in the course of disease, the viral yield might become low. And as shown by sir in a slide, that the lower respiratory tract samples have a very, very high yield, that is 93% from bronchoalveolar lavage fluid, which is not easily available and usually not done. So swab the sensitivity that comes from the swab is around 60 to 70%. You might miss case, and you need to repeat the test. Yes.
Right. Thank you. There is another question which has come from Dr. Vani Puri Rawat of Ghaziabad. There's actually 2 questions. One, I think, already got addressed. That is, protocol to be followed for emergency obstetrics in COVID pandemic. This is one. Second question is, if history of cold and cough to the close contact is there, how many tests should be performed and at what intervals? Sir.
So the first question is regarding the emergency obstetrics. The protocol is same. Only thing is, when there is emergency, sometimes we do not have time. But we will require only 10 seconds to know whether there is a TOCC. TOCC means travel, occupational hazard, cluster, contact, and whether she is having any respiratory symptoms, illness or not. So it will take only 10 seconds to ask or to get this history. If this is positive, and if you have time, and if your center is not a COVID-19 designated center, and if you have time to refer the patient, you can refer the patient. If your center is COVID-19 designated center, if you have all facilities, or if you do not have time, if you have facility and time is there, you can go for the test also. But here again, swab test may take a long time. Rapid test is still not everywhere available, and also it will take 2 hours. So in that time, if TOCC is there, always consider she has COVID-19 infection. For the safety of patient as well as our staff member and for our safety, always consider she has COVID-19 infection and take all the measures for the protection which are required for the COVID-19 infection. Full PPE and everything whichever is required, follow all the protocol.
Right, sir. So next question comes from Dr. Priyanka Gaur from Jabalpur. She is telling that patient with no history of travel or contact or symptoms underwent LSCS for obstetric indication. Discharged uneventfully, complaints of dyspnea alone, no fever or cold or cough is there. What could be suspected or what investigation is advised?
There are many indications, many reasons can be there. It also, when these symptoms appear, is also very, very important. During cesarean section, immediately cesarean section, after a few days, it also has some importance. And in obstetric, we all are knowing that for dyspnea or for this for these all reasons, many times the pulmonary embolism, amniotic fluid embolism, there are many other causes. We have to rule out all these causes first because she does not have the history of contact, travel and fever or anything else before performing the cesarean section. So anesthesia complications, overloading complications, if you have given, if blood is given, then it may also can cause some problem at lungs. So many other causes are there. We have to first rule out all these things. If she is having preeclampsia, hypertension, then also pulmonary edema can be there. So there are many causes. We have to rule out all these causes first. It does not mean, but we should also keep a COVID-19 infection. We should also keep this suspicion in our mind.
Right. So from Bangalore, a question comes from Dr. Indira Dunn, that any particular type of PPE and GSM is recommended? Any light can you give on that?
GSM is something like grams per square meter of fabric. Usually the PPE which I have been reading quite a lot, but I have never found any mention in any of the WHO documents about the PPE GSM. I have found some for Ebola, and for Ebola around 55 GSM should be sufficient. Currently the ones which we are using in our hospital is around 90 GSM. So you can ask your provider what GSM is he giving, because it is made up of either Tyvek, which is a polyethylene fiber. The material of the PPE is polyethylene fiber, which is a non-woven fabric, and it is fluid repellent. It's a fluid repellent fabric, and the GSM can be easily asked. So it should be somewhere above 65 at least to give you a good amount of protection. The ones which, as I told you, we are using is 90 GSM at our hospital.
Thank you.
So 65 should be sufficient. 65 to 70 should be sufficient.
Okay. Dr. Anupama from Hubli, she is asking to Alpesh sir. Sir, you have mentioned that there is no need for sonography for MTP services in this COVID crisis. But will this be acceptable under MTP Act, which mandates a compulsory sonography, and will we be safe under law?
First of all, there is no recommendation for sonography in MTP Act. So this is some, it is not there not at all in the MTP Act. There was one case in Supreme Court where it was incomplete abortion performed by a surgeon, and then case was in the court, and it was observation of the court that if sonography would have been performed, doctor could have come to know that products are still there and it is performed incompletely. But it is not in MTP Act. This is just the observation of the Supreme Court, Honorable Supreme Court. It means, observation means it is advice, and it is always considering the present situation. Suppose someone is performing MTP in a periphery where sonography facility is not available, then for that place, court will never expect sonography should be done. So advisory observation is as per the situation and surrounding and facilities considering. So for this crisis, we can consider this as the health crisis where telemedicine was not previously allowed in our country. Why it is allowed now in our country? Because we wanted that there should be minimum visits, minimum interaction, minimum contact with the patient. So in that situation, in that scenario, definitely there will not be any problem of sonography. Not only that, we can say ISO, which is the Association for the Sonologist or Sonography, it also suggests that there is no need of sonography. So there is, and first of all, it is not there at all in MTP Act.
Right, sir. So there are several questions which came regarding what should be the advice regarding breastfeeding in COVID positive patients.
So it's a good question. Breastfeeding, usually all the guideline, whichever guideline you see, our FOXIS guideline, WHO guideline, ICMR guideline, RCOG guideline, majority of the all the guidelines suggest breastfeeding is safe and it should be allowed. Only ACOG guideline is having some difference of opinion. Breastfeeding as such, virus is not found in the breast milk. Only problem in breastfeeding is close contact. And if mother can take all the precautions like hand washing before taking the baby, hand washing after taking the baby, and keeping this all the surfaces disinfected in the room, keeping baby away 1 meter from her, 1 to 2 meter away from her in the same room. And if at all, if she is giving breast milk, if she is not able to give it directly, and if she is giving extracted milk with breast pump, then if proper care and hygiene and cleaning of breast pump is done, then there is not a problem in breastfeeding. So breastfeeding is allowed, and not only that, rather it is very, very important for immune system of baby.
Right, sir. Sir, we have seen that in the comorbid cases, like in hypertensive and the diabetic patients, they are more likely to get infected. So here a question came from Dr. Asha Nikte from Akola. She's asking whether a pregnant woman are more likely to get infected in COVID. Is there any chance like that?
As such, there is no evidence suggests that pregnant woman is more vulnerable, more susceptible. But if you look at the other viruses like SARS virus, previous other viruses, we have seen that pregnancy is more affected. The only reason is during pregnancy, there is physiological changes occurring in the body. And there are lots of changes also occurring in the respiratory system also. And we can say the immunity level is also low compared to non-pregnant women. And one more thing is nutrition deficiency, nutritional problem are also there. So it is believed that probably they may have more severity when they are infected. But for getting infection, there are no such evidence at present. And also there are not such evidence for the severity. But it is believed probably they may have more severe infection.
Right, sir. So another question came from Dr. Vidya Pradeep. She's asking to you, sir, what's your advice on protective gear to be worn during vaginal delivery or LSCS of low-risk pregnant, low-risk patients for COVID-19?
Low-risk patient for COVID-19 means if tests are done, if tests are negative, if she does not have COVID-19 infection, the thing is different. And if she is having COVID-19 infection, or if we are suspecting that this patient may have COVID-19 infection, then the things are different. If we are suspecting And if we have time, we should go for the test. We should confirm whether she is having infection or not. If she is suspected, strongly suspected, or if she is having COVID-19 infection, and if we do not have facility of separate operation theater at our hospital, we should refer this patient to the designated COVID-19 hospital, and we should not operate this patient at our place. If we are working in COVID-19 designated hospital, and if she is strongly suspected, or if she is confirmed, then we should wear all the full PPE, full protection should be there.
Right, sir. There's a question for Dr. Rupika from Dr. Alpna Kansal from Ghaziabad. She's asking, why should CO2 insufflation be avoided? What is the theory behind it?
CO2 insufflation, their theory, I don't know the theory about it, but and I might not be able to answer this question also very well. I honestly don't know the answer to it. Why should CO2 insufflation be avoided? That was in our endoscopy, as I said, SAGE guidelines, and it says that CO2 insufflation should be avoided in laparoscopic surgeries. I have no answer to this. Maybe sir can answer that, because he must also be doing laparoscopic gynecological surgery.
I also don't know in detail.
Right. So we come to next question, which is very important in today's scenario. This comes from Dr. Gitanjali Belekar from Mumbai. She's telling, if the pregnant patient is totally asymptomatic, no history of contact or no history of living in hotspot area also, is it compulsory to test COVID-19 before delivery or section?
No, not at all. If she does not have any symptoms of SARI, if she does not have contact, if she does not have does not residing in the cluster area, or if she does not in close contact of any proved COVID-19 infected patient, we do not require. Even if only she is having fever, then during labor something is justifiable. If nothing is there, we should not worry and no need of testing. Yes, there is a risk. Sometimes she may be a symptomatic carrier, but in that way we have to go for testing for the all pregnant women. That's a different thing.
Right, sir. Right. Sir, another question came from the Northeast. Dr. Deepak Kumar Sharma is asking, if patient come with fever with TOCC with pregnancy at any trimester, but with travel history, whether we can treat her in COVID-19 non-designated hospital, means COVID-19 non-designated hospital, or not. So I just reframe the question. If the patient is coming with fever without TOCC with pregnancy at any trimester, but with travel history, whether we can treat in COVID-19 non-designated hospital or not? From Dr.
Here patient is having fever and history of travel. What I understand is, am I right? And no other history. If patient is having history of travel, if patient is having fever, we should ask for the investigations. And if she is turned to be positive, then we should refer, as I told you, we should refer her to the fever clinic. There are separate fever clinics which are dealing with such type of patients, and we should not treat her at our place. If reports are negative and no other problems of SARI, then better we can, then no problem, we can treat her at our place.
Okay. So from Raipur, Dr. Subuhi is asking, if we have done LSCS on a suspected patient and taken all precautions, do we still need to isolate ourselves and our staff till the report comes?
If you have performed on suspected patient, his question is like this, na?
Right. So this question is like, yeah, she has performed in the suspected patient and taken all the precautions. After that also,
it is important what are the criteria for this suspected patient. Suppose TOCC or suppose SARI is there. What are the, I don't know how it was suspected this patient is having COVID-19. But if you are suspecting the patient and if report are still report is waiting, better you should not operate any other patient. Sometimes you have seen the famous that singer, I forgot the name,
Kanika Kapoor, sir.
Kanika Kapoor.
Yeah.
And she had gone at many places and report was waiting. Even some MLA and MP also report were waiting and they have gone to many places. And one case also against doctor, why fever was there and he was continuing his work and then turned to be positive nearby Pune. So why she has not informed earlier? So better we should wait for the report to become. If she is positive, turn to be, then we should also go for the test and then only we should go ahead.
Right.
Better for safety. It is not recommended everywhere, but it's for safety of us.
Mr. Pushan, I'll just
Yes.
go back to that question that one colleague of mine has asked about CO2 insufficiency, though I don't know the exact answer to that. And I tried looking for it as well. But the only thing that comes to my mind right now is maybe when the pneumoperitoneum is created with CO2 insufficiency and the gas has to escape later on, it might be carrying some viral particles with it and cause some kind of aerosolization of viral particles. I think that might be the only reason why CO2 insufficiency is contraindicated. I'll still ask my endoscopist and maybe get back to her if she needs the answer. She can write to me and I'll try to find out for. But this is the thing that logically comes to my mind, that
Right.
escaping gases might be aerosolizing some viral particles, and that is why it should not be.
Right. From Sholapur, Dr. Patwardhan has also given one reaction on this question, that no CO2 inflation because while deflating the abdomen, aerosol may be generated, which may be infectious.
Yeah, so
Risk
that was
to
what
the
I.
operating persons. Yeah.
Yeah, yeah. So if
So,
you don't have a HEPA filter in your hospital, operating area or endoscopy area, then that might get aerosolized. And I said that ventilation has to be there. When we are doing some OT procedure or endoscopy, and we cannot do it with the positive pressure, as we saw, what I read was, you leave the OT closed for 30 minutes post the procedure, so that all the ventilation carries away the this viral aerosols and the OT is clean. The air changes will clean. I think in the NABH OT guidelines also you will find around 25 to 30 air changes are required per hour in a super specialty OT or clean OTs or ultra clean OTs. So with I think 20 air changes of recirculated air and 4 air changes of the fresh air. So depending on that, 30 minutes should suffice. And your hospital may be having a different workflow. Like for us, we have around 40 to 45 air changes, 100% pressure. So still we keep it closed for 30 minutes. So in case you don't have HEPA or ULPA filters installed, as the doctor has clearly said, the person who I don't know the name, that these may cause aerosolization and may be risking the operator. I'll have to read, but I think this is a logical explanation why CO2 insufficiency may be dangerous in these COVID pandemic times.
right. Sir, one question came from Dr. Madhu Singhal. This same question came from many other doctors. Dr. Madhu Singhal is from Ghaziabad. She's asking, is wearing PPT kit while doing cesarean in non-suspected cases, is it compulsory to do?
What? Could not get.
Wearing PPT kit. Wearing
Yes.
PPT kit while doing cesarean section. Is it compulsory? In
No.
non-suspected COVID case?
No.
So it's not compulsory. Yeah.
Because at present there is a scarcity of this PPE kit. We have to wear it rationally. We should use it very much rationally. At present, there is no indication for such type of, but in some of the corporate hospital in Mumbai or at some places, this is the practice. That's a different thing. But at present, there is no such recommendation.
Right.
But of course, we should take as much possible as precautions care. Now, main thing is at least minimum N95 mask. Minimum is N95 mask. We all have now HIV kit.
Right.
So in our hospital, we all have HIV kits. So now it is very much easily available, HIV kits are. So that's a different thing for your precaution, our precaution if we use any of such thing. But at present, there is no recommendation and we should use it very much rationally.
So the Dr. Shraddha from Chennai, she's asking, her question is regarding that only. The kit or the PPE kit which doctors are using for HIV cases is the same kit they can use for COVID cases also?
No, it's a different kit.
Yes. So if I may answer this, COVID kit requires you to cover yourself from head to toe. You must have seen pictures emerging from various COVID care centers or wherever, and even some of the videos which have been shared on WhatsApp, that if you are wearing an HIV kit, then at least wear a complete hood that covers your shoulders, and your gown should be covering you adequately in the back as well. That is to to prevent any aerosols impinging on your skin, any contact with the patient body secretions or respiratory aerosols during intensive care, during critical care, or during any aerosol generating procedure. So that kit is different from the HIV kit. And if you are wearing an HIV kit, then you please augment it with other things like wearing a hood over it, or maybe an N95 and a visor, whatever you can these days people are doing a lot of jugaad regarding those things. So you can, but the only thing is to minimize any exposure to your skin uh, from the aerosols or patient's body secretions.
Right. So, many questions are coming. Can we go for more 2-3 questions?
We can go, but after that at 5 p.m. I have another webinar.
Okay, sir, it's already 5. Just last 2 questions, sir. The penultimate one is from Dr. Aparna from Hyderabad. She's asking how to treat a pregnant woman if she is already suffering with gestational hypertension and found other symptoms of COVID-19.
There is nothing difference in the management whether patient has gestational whether patient is having hypertension or any other complication. Only thing is, if patient is having COVID-19 positive, then we have to take all the precautions and we have to manage as he is an infected patient. Only thing is chances of severity, chances of some respiratory problems may be more, and we should be very much watchful, careful for that.
Right. Sir, the last
particularly
question
fluid restrictions should be there.
Okay. So last question of today comes from Dr. Radha from Tirunelveli. How practical is the use of UV rays as germicide in COVID-19? Are they have any side effects? Are sunlight's UV rays the same?
Better madam can give this answer.
UV rays as such are carcinogenic. I mean, what exactly is the usage madam is asking for? I mean, disinfection of what? UV, GI, I mean, where do you want? Is there a specific spectrum of UV lights or UV lamps which are fitted in the OTs or inside the HEPA filter ducts to cause irradiation disinfection? But for disinfecting any other things, you like our biosafety cabinets or BSL2 safety cabinet, whatever, we use UV lights. But and even in TB room, sometimes we use UV lights. But what for is, I mean, can she specify what is her question? What does she want it?
This much has only come, madam. I think if anything extra means anything more information will come.
Like other disinfection, we have proper disinfecting agent for surface or environmental disinfection. You can use your common bleach that is just 1% hypochlorite every day to be freshly made. For every other purpose, or if you can use other fancy things like maybe Virkon 1% or any hospital approved disinfectant, maybe quaternary ammonium compounds. You can use multiple things are available in the market. UV lights will require some engineering, you say the help also to be installed. What is the spectrum and all, you have to know about it. So you should know where do you want to use your UV lighting for what things. For disinfecting purpose, if you have surface disinfection things, you can do. For aerosols, if you want to remove from a room, natural ventilation also can be more than enough. If you don't have a HEPA filtered room and you're using it over there, if you have natural ventilation and there's adequate ventilation, then maybe fitting an exhaust fan will clear off the aerosols also. So you can work around those things. And apart from that, I don't know, UV rays will cause they are carcinogens. They can cause burns if they are not used properly. So,
Sir, yeah, though many questions are coming, we will try to take these answers from you personally by contacting with you. As you have to leave for another webinar, sir, hereby from Indoco Remedies, we express our wholehearted gratitude and thanks to Sir you and Dr. Rupika Bedi. And it's our great privilege to get today with us Dr. Alpesh Gandhi, who is Foxy President. And from his busy schedule, Sir has managed some time to come and give his view about lots of problems and the tips on safety. Few days back, he had a video conferencing with Prime Minister of India, and I hope lots of things which he has told has come up from the discussion from there. I hope, doctors, very soon we will see a new morning, a new day where you will be rushing to see the patients in the OPD or to do the cesarean sections in the OT, and we will be rushing very soon to meet you. With that hope, we are signing off. Thank you to all the doctors for logging in, and thank you again to Dr. Alpesh Gandhi and to Dr. Rupika Bedi for giving us time and sharing your views. Thank you so much.
thank you so much.
Thank you.